Hello, everyone. I am Dr. Rennie Butler at Yale University School of Medicine. I'm here to talk to you today about digital breast tomosynthesis. Thank you for inviting me. The role of preoperative MRI is still debated. However, it is known that preoperative MRI detects additional unsuspected cancers in both the ipsilateral and contralateral breast in a significant percentage of women. This table shows a number of studies, including our own review of our data at Yale in 2012, of the additional cancers detected in the ipsilateral cancer of newly diagnosed breast cancer patients. You can see here in the last column that it ranges between 14 and 27%, meaning that 14 to 27% of women with a new diagnosis of breast cancer have additional breast cancers in that same breast that were not identified. The debate surrounds the issue of the clinical significance of these additional cancers. If all of these additional cancers are likely to grow into significant invasive cancers in the woman's future, then we would expect a recurrence rate of at least 14 to 27%. However, we know that our recurrence rates are much lower than that. So clearly, some of these additional cancers identified preoperatively are eradicated, most likely by the adjuvant radiation therapy that patients who are treated with lumpectomy receive. However, the recurrence rate is also not zero. There is a finite recurrence rate and rate of second cancers in women with a personal history of breast cancer, and therefore some of these ipsilateral cancers may actually be clinically significant. The same is especially true for contralateral breast cancers, because the contralateral breast would not receive any adjuvant radiation treatment. In studies looking at the contralateral cancer rates in women with a newly diagnosed breast cancer, the incidence is very stable. It's 3 to 5% in all of the published studies, as well as in our own internal review. Here's an example of a patient that illustrates that point. This was a screening mammogram in a 62-year-old woman. In the middle is her prior mammogram. And you'll see it's a little bit of a complex mammogram with multiple small masses and asymmetries. However, if you compare the prior mammogram to the current mammogram, you'll notice that this particular mass in the superior posterior portion of the left breast was not present on the prior mammogram. This is a new finding. It is not circumscribed. There is some suggestion of speculation here, and it is a suspicious finding. This was identified with ultrasound and biopsied, and it showed invasive lobular carcinoma, intermediate grade. What happened next is that because it was invasive lobular carcinoma, and we know that this histology is more commonly underestimated in terms of its extent, the patient underwent an MRI. And what we found is that she had multiple additional unsuspected cancers in the same breast. This is the biopsied cancer. In fact, there's a little signal void here, this black spot from the post-biopsy marker clip. But in the same slice, knowing this is in the superior lateral breast, we see that there is another mass in the superior medial breast. And as we scroll down, we see another one in the inferior lateral breast. So multiple quadrants are affected, meaning that this patient would likely benefit from mastectomy rather than a simple lumpectomy. In addition, the patient had an unsuspected contralateral breast cancer. So this patient had much more extensive disease than initially suspected. And I'll just discuss two studies with you that examine the impact on surgical management from preoperative MRI. The first one is a meta-analysis of multiple 19 prospective and retrospective single institution studies. And it showed that preoperative MRI altered surgical management in 16.6% of patients. In 11.1%, this was a correct change in surgical treatment, in other words, a true positive. And in 5.5%, it led to surgical overtreatment, a false positive. However, when they reviewed the false positives, they found that the surgical management in these cases had been changed on the basis of the MRI findings without first obtaining tissue diagnosis, and that this surgical overtreatment could have been avoided by preoperative biopsy of any additional findings, which in fact is our current practice. In another study that we presented from our own series at Yale, we reviewed 154 patients, 4 of which had bilateral cancers for 158 cases. 61% of these patients underwent preoperative MRI and 39% did not. And so we asked the question, how did that affect the likelihood of positive margins and other surgical outcomes? And what we found is that patients who had an MRI had a lower rate of positive margins of only 13%, while patients who did not have a preoperative MRI had a higher positive margin rate of 28%, and this difference was clinically significant. Patients who underwent preoperative MRI were less likely to require re-excision and less likely to have a mastectomy. And I'll leave this discussion with just one last example. This was a screening mammogram in a 66-year-old woman that showed some new clustered linear and even linear branching calcifications. This is a highly suspicious distribution pattern, and these were biopsied and showed invasive ductal carcinoma grade 2 with DCIS. This is just the post-biopsy mammogram, and I show it to show you where the biopsy clip is, telling us, where in the breast this was centered. The patient underwent a preoperative MRI, and it turned out that the area we had biopsied was only the tip of the iceberg. We had biopsied the anterior margin of this entire process, which extended a significant distance posteriorly, almost to the pectoralis muscle. And after we biopsied the posterior extent using MRI guidance, you can see this was the original biopsy clip, and this is the MRI clip showing you the extent was significantly greater than originally anticipated. And because this patient was not likely to have a good cosmetic result with this extensive disease, her surgeon recommended that she undergo mastectomy. So the takeaway points from this discussion are that we know preoperative MRI detects additional ipsilateral cancers in 14 to 27% of newly diagnosed breast cancer patients. And while all of these are probably not clinically significant, some of them may be. Preoperative MRI also detects additional contralateral cancers in 3 to 5% of newly diagnosed breast cancer patients, and the contralateral breast does not receive any radiation therapy. It does receive, of course, a systemic chemotherapy in patients who require chemotherapy. So it's uncertain how many of these are clinically significant, but it's possible that some contralateral cancers may be as well. If it's not performed in every case with newly diagnosed breast cancer, it may be at least helpful to perform it in some of the high-risk clinical scenarios. In our practice, that means that we do preoperative MRI in patients with large tumors, in patients with multiple synchronous tumors, and in patients with invasive lobular carcinoma, which is notorious for being underestimated for its extent of disease, both clinically and with all other imaging modalities.